Great, thanks, Tim. Dr. Alarcon, welcome and thank you for joining us this evening. Dr. Alarcon is the Chief Medical Officer at Lorette Health Center. He has been with Lorette since its inception. He's a dedicated advocate for improving community health. Dr. Alarcon focuses on addressing substance use disorders, obesity, and access to quality health care. He's board certified in internal medicine, obesity medicine, and addiction medicine, scoring in the top 10% nationally on the obesity medicine board exam. Beyond leading Lorette's medical staff, Dr. Alarcon is the founder of Atlantic Family Physicians, owner of Healthy Outcomes Medical Weight Loss Center, and serves as the medical director at Addiction Medical Solutions and Medical Facility. Welcome, Dr. Alarcon, and we're going to turn it over to you.
Thank you very much, Christy, and thank you all for having me here today. Looking forward to talking to you all and answering all your questions. And thank you for the introduction. So I want to talk to you and give you my experiences in working with addiction. And we're going to start by telling you a little story of an actual patient of mine. This is JC. JC is now 28 years old. He initially came to our office at Lorette Health Center. He was referred to us by his probation and parole officer after he was released from jail at age 27. So his journey with addiction started when he was 16 years old. He was a victim of a motorcycle accident where he broke his femur and his shoulder, and he was then prescribed pain medications, specifically oxycodone. He says he liked the way it made him feel. At that point, besides controlling his pain, he got some sense of well-being and a little bit of euphoria, and he just liked the feeling. His pain medications prescription, stopped after a little while, but when he was 17, he started experimenting on his own, buying illegal oxycodone on the street. He was also at that point smoking. He actually started smoking when he was 11. He was also using marijuana and at times drinking alcohol with his high school friends. When JC was 23 years old, his girlfriend got pregnant. She was using heroin too. Tim, I think we skipped a slide.
Sadly, what I have is blank. Let me go back to the original deck and see whether something didn't grab over. It wouldn't be mini-med if we didn't have a little technology blip, so just hold on for 1 second.
But I can just tell you a little bit of what happened in between slides there. Tim, it's okay. I could just tell you the story. We can go back to the slides.
Okay, is that the slide you wanted to see?
Yes. So at that point, so when he was 17, as you saw in the previous slide, he was already smoking, using alcohol, marijuana, and experimenting with pain pills. He finished high school, and as soon as he finished, he got a part-time job at a grocery store. However, JC spent most of his money buying pills. He missed many work shifts and actually tried many different jobs, but because of missing work, he got fired from multiple jobs. And he missed shifts and work many times because either he was intoxicated or he was trying to buy drugs on the street. At some point, pills became too expensive to buy and harder to find. As you probably heard, there is a lot of restrictions on prescribing painkillers in the state of Delaware for good reasons. So he started experimenting with heroin when he was 20 years old, and initially was snorting it, but over time he progressed and started using IV. He felt that he needed more and more. He developed what's called tolerance. And he says that at that point, he was not using heroin to get high, but just to function, to feel normal. When he was 21, he started experimenting also with cocaine and later on with meth, crystal meth. When he was 23, his girlfriend got pregnant, and she was also using opiates. She was using heroin. They both tried to get treatment. They came to our practice. We put him on a medication called Suboxone. It's a combination of a chemical called buprenorphine and an opiate blocker called naloxone. Unfortunately, he had multiple relapses and mostly from peer pressure. And he was hanging out with a lot of friends and acquaintances that were using heroin, and they were coming to their house and freely open, heroin bags, and unfortunately that triggered multiple relapses. His baby girl was born, but unfortunately she had to be in the ICU because she developed opiate withdrawals, which is called a neonatal abstinence syndrome, because mom was using opiates that were transmitted or passed to the baby through the placenta. When the baby was born and cut off those opiates, the little girl developed opiate withdrawals and had to be put in a morphine drip at the hospital. So JC's girlfriend stopped using heroin at that point after witnessing and a little traumatized of what her daughter had to go through, and also for the fear that the authorities will take her child away. So she came back to our office. She was started on Suboxone, and she was successful. Unfortunately, JC did not follow treatment at that point. He kept using heroin. However, we managed to keep in touch with him because he came multiple times to his girlfriend's visits to us, and we had the chance to kind of keep up with what was happening to JC. The next slide. So he still could not keep a steady job. He ended up robbing a local liquor store, and he got arrested. He stayed at that time in jail for 30 days. And when he was put in jail, he was not treated, and he went through terrible withdrawals. He said it was one of the worst experiences of his life. He came out of jail after 30 days, and he tried to use heroin again. So what happens is that, remember when I said earlier that JC required to use more and more and more because he developed something called tolerance. So that tolerance starts winning down and disappearing after 3 days of not using opiates. And after 10 days, it completely disappears. So when JC came out of jail, he tried to use the same amount of heroin he used before he went to jail. He injected 6 bags of heroin intravenously, and unfortunately, he overdosed. He was with his girlfriend at that point, who was present. She called 911, gave him Narcan. She had a bag of Narcan that we gave her at Lorette at her first visit. But at that point, she was kind of fed up with this and kicked him out of the house. And JC was homeless for a while. He was incarcerated again for a DUI at age 26. And then he was sent to us under court order to receive treatment for opiate use disorder or substance use disorder. If not, he would be incarcerated again. So we started here on Suboxone 2. And after several ups and downs, he finally stopped using all illicit drugs. So JC now has completed 1 full year free of drugs. He has a steady job. He moved in with his girlfriend again. He's no longer hanging out with the wrong company. They actually moved to a different town just to avoid the peer pressure and the exposure to drugs. His baby girl is now 4 years old. She's healthy and happy. I actually met her. She's a cutie. JC and his girlfriend are still on treatment with us, and she's pregnant again. And interestingly, JC, after all his experiences, he started receiving training to become a peer support specialist to help other people that struggle with addiction. So that's the story of JC, successful story. We see this many times with patients that struggle with addiction. This is all what he went through is actually relatively common. Next slide, please. So if you remember what I told you about JC, he started experimenting with drugs at an early age, right? He started smoking when he was 11. He was exposed to opiates at age 16. He started experimenting himself with illegal opiates when he was 17. When he was in his early 20s, then cocaine, crystal meth. He was already using alcohol and marijuana and smoking. And there is a reason for this. Most of the patients we see that struggle with drug addiction start at an early age. There is a reason for that, and there is an area of your brain called the prefrontal cortex. And you're probably familiar with that. Your brain has multiple areas and nuclei and centers in your brain that control different functions. Well, the prefrontal cortex is the area of your brain that helps you make rational decisions. It's like the executive decision maker, let's call it, is like the president of your brain. It's the part of your brain that tells you, do this or don't do that. It's very simple, very straightforward. Unfortunately, our brains mature gradually. The prefrontal cortex is in the front of your brain, and our brains start developing from the back part, which is called the occipital lobe, forward. Therefore, the prefrontal cortex, the president of your brain, is the last area of your brain to mature and usually reaches full maturity or development at age 25. So that explains why JC and multiple other people that are young, under the age of 25, do not have the ability to make a lot of full, complete rational decisions. And when we are young, we are more prone to risk-taking, experimentation, and things like that. And that's what happened to JC in this case as well. Next slide. So what is a substance use disorder? There is a lot of stigma and misconceptions on this. What we used to call drug addiction, and now we call it substance use disorders, is really an illness. It is a chronic illness, a chronic brain disease. There is a lot of changes that occur in the brain that will make people get addicted to substances. It's maybe the first time somebody uses a drug is a choice. After that, people just cannot stop it and need help. Next. So what happens in the brain? Let's see, let me tell you a little bit more of what happens in the brain of somebody that struggles with addiction. Next slide. So there is an area of your brain. So what you see there is, let's talk about the mesolimbic system. The mesolimbic system is an area in your brain that controls pleasure, controls reward. So when you are experiencing pleasure or reward, let's say you like cheesecake and you eat your favorite cheesecake, your mesolimbic system fires up and releases a chemical called dopamine and gives you that sense of pleasure and reward. So was this found? Back in the 1950s, a couple of scientists put electrodes in the brain of rodents, and they started giving mild electrical shocks to different areas of your brain, and then they were observing behaviors. Let's say if they gave a little shock to an area that causes pain, there is a part of your brain that controls pain called the thalamus. When they shock the thalamus, the rats run away and never push the lever to receive another shock again. So the rats were allowed to press the lever to receive shots themselves. They noticed that there was a group of rats that were constantly pushing the lever and receiving shots in their brain. And these were the rats that had the electrodes attached to an area of the brain called the septal area, which is part of this mesolimbic system, part of the reward system. So these rats were shocking themselves to receive pleasure. Actually, one of the rats in the experiment pressed the lever 7,500 times in a 12-hour period. So let's look at this mesolimbic system. Let's look at the brain of JC. So the mesolimbic system, and it's called a system because there are several players in this system that interact with each other. There are different areas of your brain that interact at the same time to make you use something or a drug or not. Let's say, for example, there is an area called the ventral tegmental area that is a part of your brain that produces the dopamine, which is the chemical that gives you that high, that when you use a drug and people say I got high, that's a lot of dopamine being produced in the ventral tegmental area, and is released in that area called the nucleus accumbens, and that causes reward. So when somebody uses a drug, then it releases a lot of dopamine and causes a lot of pleasure and reward. There is another area that interacts at the same time, which is the prefrontal cortex that we already talked a little bit before. That's, as I said, the president of your brain. That's the part of your brain that's gonna tell you, hey, don't do that, don't use heroin, that's bad, right? That's your prefrontal cortex giving you a rational, decision there, don't do that. Then there is another area called the hippocampus, which controls your memory. And that's the part of your brain that at that point is telling JC, listen, remember when we used heroin last time? We felt great. So let's use it again. Or at the same time, you can tell JC, remember last time we used heroin, actually we felt so bad that probably we shouldn't use it again. So it's a lot of information coming at the same time as JC is holding a bag of heroin, right? And then you have the amygdala, which is your stress center. It's also part of the mesolimbic system. And it's the center of your brain that controls stress and emotion. It's, for example, the part of the brain that's telling JC, listen, what is stressing him out? What if the heroin I'm going to use is laced with something bad, has too much fentanyl and I'm going to overdose, or has other chemicals that now are mixing in with heroin, like psilocin, and I'm going to get I can overdose and die. So it's the amygdala is giving you the stress piece to make the decision to use or not use. So at the end of the day, the interaction of all these, your memory telling something, your reward and pleasure center telling you something, your stress center telling you something, and your prefrontal cortex telling you something, the interaction of all these, one or the other at the end is going to dominate. Now, let me tell you that the reward center, your nucleus accumbens, where the dopamine is released, is extremely powerful, usually dominates all the other components telling you not to do something, but the reward is very powerful. The reward center is very powerful. A simple example to tell you about this. For example, let's talk about something else that gives you pleasure, let's say food, okay? And you can eat for two reasons, right? You eat because you're hungry, or you eat because you want something delicious and you're awaiting reward. So let's say you start eating because you're hungry. You eat a big piece of steak and then you're full, you're not hungry anymore, so you don't want to eat anymore. And then comes grandma with a big tray of your favorite cheesecake, and your nucleus accumbens immediately start getting dopamine, and you start getting that high sensation just by looking at the cheesecake, and you start salivating and craving it. And guess what? You are full, you ate your big steak, but guess what? You still eat your cheesecake, because that reward center is so powerful that it's telling everybody else, I don't care if I'm hungry, I want the pleasure of this, I'm gonna eat it anyway. So the same thing happens with drugs of addiction, because the pleasure that you are awaiting from them is so powerful and so necessary that it overcomes and overpowers any other areas of your brain telling you not to do that. Next one. So on top of that, the main thing we treat in our practice is addiction to opiates, and why is addiction to opiates worse? There is an extra component that pushes or makes people or makes impossible to stop opiates once you get hooked to them. So like any other drug, opiates also give you release that dopamine in your mesolimbic system, and gives you the high, and gives you the liking and the wanting. You start using because you like it, like JC started, say it made him feel good. And at some point you just want it, because not just because making feel good, but you start kind of becoming addicted to it, and you need it to avoid withdrawal, so you want it and you have to have it. But on top of that, opiates have a very unique effect. Some of you might have heard, or all of you might have heard of endorphins. Endorphins is the chemical term for our own opiates. Our brain produces our own opiates, and that helps us deal with pain, stress, happiness. When JC started using heroin, he shut down that factory. So his brain stopped producing his own opiates because it didn't need to. JC was giving his brain all the opiates the brain needed in the form of heroin, and the factory shut down. And after it shuts down, it's very hard to start working again, especially if you keep using, heroin or other opiates. So as I said, your endorphins, your own opiates help you deal with pain, stress, happiness. And if you remember the story of JC, he said that he wasn't using heroin to feel high or to get high. He was using heroin to function or to feel normal. Because without heroin and without his endogenous or own endorphins or own opiates, every pain was more painful, every stress was more stressful, every happiness was less happy. If you have met somebody that struggles with addiction, you will see that a lot of these people are very volatile, very emotional. They have very heightened emotions because they cannot control that. And they tend to be depressed as well because they don't have those endorphins that makes them feel good. Every stress becomes magnified because they don't have the endorphins to control that. The pain that they had before they started taking opiates is now magnified because they don't have the mechanisms in their brains to control pain anymore. So yes, their lives is not just the high, it's not just the withdrawals, it is also the need to use opiates to feel normal and to function. So that's one reason why the addiction to opiates is worse than others. Next. So there are many reasons why people end up using substances. Like there is evidence that there is a genetic component. There is a lot of research that shows that If mom and dad are addicted to substances, the kids are probably going to end up, some of them are going to end up at a higher risk of falling for substance of abuse. There is environmental stressors, like even stress at work or peer pressure, like social pressures. There's personality characteristics. People say, I don't have, I hear this all the time from patients, I don't have an addictive personality. That necessarily doesn't exist, an addictive personality, but some people have personality that makes them more prone or puts them at a higher risk of developing addiction, like people that tend to be more impulsive, or people that have low self-esteem, etc. And there are behavioral health or mental health conditions that also increase the risk of addiction, like anxiety, depression, especially PTSD, schizophrenia, and things like that. Next. And it's a big problem in Delaware. We have been dealing with this for a long time. Delaware ranked third in the nation, as small as we are, for being the state with the highest fatal drug overdose death rate in 2022, which is coming down, but is still very high. And according to the Delaware Division of Forensic Science, in 2023, last year, there were 527 accidental drug overdoses, fatal, that people that died from a drug overdose. That is, if you think about it, that is a massive number, because you're not even talking about the people that were saved. So this is the people that died. So almost 2 people every day die from a drug overdose in Delaware in 2023. Next. Only West Virginia and Tennessee had higher rates of drug overdose deaths than Delaware, according to the CDC. Next. So what attracted me to become an addiction specialist? So we all have, being a doctor in general, it's a very rewarding experience in general, but that gets magnified when you, at least in my personal experience, when you treat people with addiction. We all have done something nice for ourselves, right? We have treated ourselves with something nice many times, and that gives us reward. That actually triggers a little bit of dopamine release in that mesolimbic system and gives you reward when you do something nice for yourself. But let me tell you that in my experience, helping somebody overcome addiction is a much bigger reward. It is so rewarding and such a nice experience and an honor to be part of people that struggle with this, when you see them at the lowest probably of their lives, and you see them and walk with them and in their path to recovery, and you see them rebuild their lives, like what happened to JC. Remember, his girlfriend kicked him out of the house. He was incarcerated. He overdosed. I mean, he had everything bad going on for him. And now he's back with his girl, living with his girlfriend is pregnant again, and he has a job. He's actually training, and he's recovered, and he rebuilt his life, and we were part of that. And that was such a rewarding experience to live through that with JC. Next. So just a little bit of how I got here. I went to medical school in Lima, Peru. And then I moved to Cleveland, where I did my residency at the Cleveland Clinic, where I became board certified in internal medicine and primary care. I moved to Delaware in 1999, and I initially joined a private practice, and then Lorette Health Center, which, if you remember from previous presentations, were a federally qualified health center. That was in 2001. Where I now serve as the medical director. And I got interested in nutrition and obesity medicine, and I became board certified in 2012. And let me tell you, that's how I was initially exposed. And realize the benefits or what addiction meant. I encountered a lot of my patients that were struggling with obesity that were actually addicted to food, and seeing them overcome them and lose weight and get healthier was very, very, very rewarding. And I decided to pursue certification in addiction medicine in 2018. Next. In Lared, where we work, we focus a lot on the needs of the community. We like to address what the community needs. We treat a lot of people that are not insured, or underinsured, as well as people with full health insurance. But we try to look at what the community needs, and primary care, addiction, obesity, those are critical needs for Delaware. And after, as we grew, as I mentioned before, we opened in 2001. And as we grew, we realized of all the multiple needs that the community needed, including mental health, women's health. We offer prenatal services, dental health, and we help patients with transportation, translation, STD counseling, etc. And we have expanded to different towns in Sussex County. So it has been also very nice to see this grow and help the community this way. Next. So what we treat at Lared as far as substance use disorders, the most common ones, as I said, the people that we help the most are people that struggle with opiates like heroin, fentanyl, and pills like oxycodone, hydrocodone. We treat a lot of people that struggle with alcohol use disorders as well. We have a lot of patients that also abuse stimulants like cocaine, amphetamines, meth or ecstasy, or sedatives like your benzodiazepines, nicotine, cigarettes or vaping, and marijuana. Less commonly, we see people that abuse inhalants or psychedelics like hallucinogenics like acid mushrooms or PCP or ketamine. So how can we help working in a community health center? We, as primary care providers, obviously we can offer treatment. And this is important because there is a high stigma on people that struggle with addiction. People are afraid sometimes of seeking help or going to what people know as a methadone clinic because they don't want to be seen coming in there. Or they go to practices that are not used on treating addiction, and they are not necessarily treated well. Many patients tell me that, they really make me feel like an addict. And so as a primary care, we have a relationship with our patients and we know them well. And that is actually the best way, in my opinion, to start somebody on treatment for addiction of any kind with your primary care. And that's why we are pushing for more primary cares to be trained in treating addiction. We can also refer patients, of course, to behavioral health, and we're lucky to have that in our center, so we can do like a one-stop shop there. We can educate patients in harm reduction or offer them tools like Narcan kits to reverse overdoses, and just provide them education on how to prevent harm from abusing illicit substances, not just overdoses, but damage to your different body organs that can be caused by abusing substances. Next. So it's not easy. We face quite a bit of challenges, as I mentioned earlier. Stigma is a big thing. Patients are sometimes embarrassed of what they're going through, and it's important to make them feel and understand that this is an illness like any other illness, like diabetes or high blood pressure, that they will be treated the same way, and we're here to help them and treat them with respect. Because not respecting or not understanding these patients what's going to be the result? They're not going to come, they're going to relapse, and they might even die from an overdose. Another challenge, social barriers. A lot of these patients, like JC, was broke, was homeless, was out of jail, had no transportation. So we can assist patients with transportation or other things like offering telehealth visits, like we can do visits over the phone or by video, just to help them overcome social barriers as they are starting to rebuild their lives. Finances, of course, is a challenge. A lot of these patients have, like JC, coming out of jail, had no insurance, have no jobs. So we try to make it as easy as possible also. Relapse triggers is a big factor that we need to educate patients on how to avoid that. Remember, JC ended up moving to a different town because being exposed to your drug of choice can trigger a lot of cravings. JC, I remember he told me, many patients tell me, even driving by the corner where I used to meet with my dealer triggered a lot of cravings. That dopamine release in your mesolimbic system, just by driving by that area, would trigger those cravings and potentially a relapse. And of course, peer pressure is a big factor, and we try to educate patients on strategies to deal with that as well. So we offer medication treatment for substance use disorders, especially for opiate use disorders. I'm not going to go in detail, but I'll be happy to answer questions if you are interested in knowing more about medications for that. We offer counseling for patients that struggle with finances, cannot afford their medicines. We also have federally sponsored program called 340B, which gives our patients access to medications at a significant discounted price. We also offer behavioral health, and we have case managers who help patients navigate through the system, as JC trying to rebuild his life and get back into normal, society function. We help them navigate different aspects like how to get insurance and medications and food stamps and things like that. And we treat patients, regardless of whether they have insurance or not. Next. We also give patients naloxone kits for free. It's very important that anybody that struggles with substance use have that on hand. Even if family members, that people that struggle with addiction, even if the person is not necessarily using drugs, but they have a family member, we give them free Narcan kits to have on hand. Nowadays, that heroin is laced and mixed with more potent substances, the risk of overdose is much higher, and the risk of death is much higher, and the risk of not responding to Narcan is also much higher. So very important to train patients on how to deal with overdoses, and even little strategies to tell them, as you are recovering, but if you are still using, never use heroin alone. Always have somebody next to you, because God forbid you overdose, somebody has to call 911. Next. So what are the benefits of specializing in addiction medicine? Definitely value to employers is definitely with the addiction epidemic that we are facing in the US. Being an addiction medicine specialist opens a lot of doors for job opportunities. Having a certification on addiction medicine, or being board certified in addiction increases your ability to get probably better jobs or higher pay. A lot of places are looking now for addiction specialists instead of having general practitioners run their programs. Access to federal loan repayments. The Congress has passed funding of over 250,000 of student loan repayment for physicians who become addiction specialists and practice for 6 years in certain designated areas. Compensation is also higher, as I mentioned. It is estimated that physicians with board certification earn up to 67% more than those without. Next. And the benefits, the way I see it, we're helping people stop using drugs and get healthy. We are preventing transmissible diseases. People that use especially IV drugs struggle with hepatitis C, potentially can be exposed to hepatitis C, hepatitis B, or HIV. I have several patients that obviously, that do a lot of things like prostitution and things like that to get money, and that exposes them also to STDs. We're also fighting a society epidemic, and that's also something that we should be proud of. And the most important thing, as I mentioned over and over, is we are partners with patients as they rebuild their lives. Next. And that's what I wanted to present, and I'll be happy to answer any questions.
And we have questions, quite a few. All righty. Let me get myself organized here. Okay. How do Narcan and naloxone actually work?
So they are what called opiate blockers. So what it means there are opiate receptors in your brain. Specifically, there is a receptor called the mu receptor in your brain that when you use an opiate like heroin or oxycodone, that those chemicals attach to those receptors in your brain, and that's what makes the whole cascade of releasing dopamine and gives you the pleasure, etc. What naloxone does, it blocks that receptor. So you can use an opiate, and if you have naloxone there, the opiate would do nothing. So it will not work. Now, there is a risk to that as well. You have to be careful, because for somebody that uses opiates for a long time, and if they have opiates in those receptors, and you give them naloxone, you're going to precipitate severe withdrawals, because naloxone is going to come, push the opiate out of the receptor, and it's like not all of a sudden not having any opiates in your brain, and people can have very severe withdrawals.
All righty. I just wanted to mention to folks that the link to the SurveyMonkey for your attendance is in the chat. This is a complimentary question. Why is Lorette not the national model for today's healthcare?
So we're a federally qualified health center. I would like to believe that we are the national model for everything, but we are a federally qualified health center. That is by itself a national model. There are many federally qualified health centers in the US that do what we do. So we received financial assistance in the form of grants from the federal government, the state, to help people that otherwise might not get help anywhere else. People that have no insurance, people have no, so immigrants or things like that. And our goal is, as I said earlier, to make it a one-stop shop. We offer primary care, pediatrics, dental, you name it, we try. If there is a need, we try to offer. And so that is a model of practice that federally qualified health centers pursue. Lorette is one of them, and we have been very successful, thankfully. And there are many others in the nation that follow the same model.
All right. Does Lorette support the new harm reduction machines in Sussex County?
Yeah, of course. Any specific details on that in the question?
No.
Yeah, of course, we support harm reduction in many different ways, strategies. We have to understand that we have to do everything possible to prevent patients in general, not just patients that struggle with addiction, but especially for patients that struggle with addiction, to not have a bad outcome or harm. So like Narcan is one strategy, education on STDs, education on, how hepatitis B, C, HIV can be transmitted by sharing needles. And we have to understand also that when we deal with patients with addiction, there is they are not going to recover the first day they walk into Laredo. So it is a long path that will take a lot of effort and partnership with the patients and different providers. So we have to expect that some patients, many patients, will still use potentially harmful drugs as we are working towards their recovery. And therefore, during that transition, we have to do everything possible to prevent them from causing severe damage to their body or death.
Do you have any theories for why Delaware is unfortunately ranked third in the country?
There is when was this? Like maybe 10 years ago, we had a lot of prescribers of pain medications. And at that point, our pain management specialists at that time were prescribing very high doses of opiates. And very high. Delaware was on the top 1% in the nation of higher doses of prescription opiates. And that's one reason why this started. It's not the only one, but that's one reason. Accessibility also, we are very close. Our opiates most of them come from Philadelphia, and we are very close. Obviously, we have patients and dealers that just drive several times a day to Philadelphia to get product. I guess those are two potential reasons. It's very accessible. It is potentially cheaper than buying it in other big cities. But the problem with Delaware is not necessarily it's obviously how many people use, but also how many people, the main problem is how many people die from using opiates. Like in other bigger states, probably the same percentage of per capita people use opiates, but less people die. One of the reasons that more people die in Delaware, part of it is being more rural. Part of it is being that the variability of the quality of the heroin that comes to Delaware. I have patients that tell me, I tell them, how much are you using? And the answer is, depends on where I get it from. If I get it in Delaware, I have to use, a whole bundle, which is 13 bags. But if I get it in Philly, I can only use 2 or 3 bags, because if not, I will overdose. So it's very unpredictable also in Delaware what you get. And we're seeing heroin being laced or mixed with other things like fentanyl, xylazine, which is a tranquilizer for animals. And so there's a lot of risk for overdose in Delaware.
All righty. One of the students asked, I know that addiction is technically lifelong, but what is an average time frame for an individual to feel like they have control? What does that process look like in terms of the treatment?
That's a very great question. Number one is everybody's different. It all depends on for how long and how much have you used. Let's say, for example, JC, he started at age 17 and he got free of drugs at age 28. So we are talking, over 10 years of dealing with this. And he was using quite a bit. So the only way, our goal when we treat addiction, especially to opiates, is to retrain your brain to produce your own opiates again. So if we have time, let me explain a little bit more so that you understand what I'm trying to say here. So normally, as I said, our brain produces opiates, right? Control pain, stress, happiness, anxiety. When we gave heroin to our brain, we gave ups and downs and ups and downs, ups and downs, a constant roller coaster to our brain. Sometimes our brain has high doses of opiates, heroin. Sometimes it doesn't, goes through withdrawals. An hour later, another dose of heroin, 2 hours later again. So it's a really bad roller coaster, messes up your brain function, shuts down the factory. So the treatments that we have now, like buprenorphine or methadone, for example, they are opiates, but they are what called long-acting opiates. They give your brain a steady level throughout the day, instead of the roller coaster that you get with Percocets or heroin. So that gives your brain a little bit more stability. And therefore, when, let's say, you are in pain, you're under stress or happy, then your brain, having that stability, will learn to produce little by little your own opiates again when you need them. Because now they don't have the roller coaster. Your brain now has a stable level of opiates, and then we learn how to produce. And then little by little, we drop down the dose, forcing your brain to produce more, more, and more. So that's the goal, to drop the doses of the treatment little by little so your brain recovers and produces your own opiates. That is where the challenge comes. To answer the question, it will vary. If somebody used opiates for, let's say, a year in very small amounts, we can probably achieve that tapering down recovery in probably 6 months to a year. Somebody like JC probably will be on treatment for several years and very slowly will drop the doses because it will take longer for his brain to start producing opiates again. So unfortunately, I cannot give you an average, but we play it individually with every patient based on their story.
Right, right. So sort of related to that question in a way, if the brain is so overly exposed at a young age during early growth and maturation and stops part of its own chemical production, how does the brain relearn or reboot or first learn at a later age?
So there is something called neuroplasticity. Our brains are made to learn. You can learn anything you want. For example, Tim and you and I were, before we opened this, we were chatting a little bit and we were talking about tennis. So if somebody has never played tennis and grabs a racket and tries to hit the ball, probably it's going to be bad, right? But then that same person what do professional athletes do? They train and train and train and train. And what training does is that neuroplasticity in the brain. It creates new circuits in the brain that make that action more efficient. So that's why if I grab a racket for the first time, I don't hit the ball, but after 2 years of training, I'll be much better because with constant training, I created new pathways, new circuits in my brain to make more motion more automatic and more efficient. So with that concept, we can train or retrain our brains for anything we want. That's called neuroplasticity. So by doing the treatment for substance addiction, substance abuse, as we taper down, let's say, methadone or buprenorphine, or forcing the patients in any other ways to produce their own opiates, we are retraining that area of your brain that produces endorphins, that produces opiates. So it's basically that's what we're doing when we treat patients. We are just retraining their brain. It might take a while. Some people learn to play tennis faster than others. Same thing, some people will recover faster than others.
All righty. Here's one slightly switching the gears, and I smile when I ask this because I love coffee. Have you ever met anyone who struggled with a caffeine addiction?
Actually, not. I love coffee too. But let me put it this way. So coffee abuse does not meet necessarily the criteria of all the criteria for addiction, but yes, it is possible. I have patients that abuse coffee, and yes, they have cravings for coffee. The first thing they do as soon as they wake up, they have to have their coffee, and throughout the day, they have to have it, and they have to have it, and they have to have it. And also, the other piece that matches the definition of addiction is people can develop withdrawals from coffee. So when you stop, if somebody uses a lot of caffeine and you all of a sudden stop, you're gonna get the worst headache of your life, which by definition is a type of withdrawal. So yes, you can say that even though it's not a disease by name coffee use disorder, but it is, yes, definitely meets some of the criteria of addiction. Yeah, people can get addicted to coffee.
All righty. Now I'm going to frame this question carefully. If you want to go beyond the frame, that's fine. From a medical perspective, how do you feel about the legalization of marijuana?
I think marijuana has a lot of medical benefits. Definitely, there is marijuana, has like 400 different chemicals called terpenoids, and the ones that people most hear about are THC and CBD, and they have a lot of benefits. They are not just painkillers; they're anti-inflammatories, they're antioxidants. They're muscle relaxants. They help people relax. They help people sleep. And two unique benefits that marijuana have is one, it boosts the opiate production in your brain. It boosts the production of endorphins. In other states, they're experimenting using medical marijuana to actually help people come off opiates. And it also takes your mind away, especially if you're in pain, trying to sleep at night, in the dark, and you're in pain, that's all you can think of. Marijuana kind of takes your mind away from that. So those are the benefits that you can find medically from marijuana. The problem with legalizing recreational marijuana is that will open the doors, that's just my opinion, open the doors to harm, which is what we're trying to avoid. Because a lot of people now could potentially not get their products at a dispensary of marijuana, but they can still buy it on the street and know they will not get in trouble or legal trouble because it's legal. The problem with street marijuana is that we're seeing marijuana being laced with fentanyl, cocaine. I've seen PCP in some of my patients in marijuana. And that is the risk, that people can not freely abuse it for no medical reason. I do believe that marijuana has a lot of medical benefits, but just using it for fun opens the door to abuse and harm.
All right. Thank you. This is a fairly nuanced question. With a genetic component for addictions, does it predispose one to a particular addiction, for instance, drugs or alcohol or sex or risk, or is a genetic predilection to addiction more generalized?
It's generalized. It's the genetic, let's put it this way, and some you might have heard this saying, genetics pulls the gun, the environment pulls the trigger. So the genetics makes you predisposed to addiction, to addictive behaviors, but it's your environment that really pushes you to fall for it. You're predisposed by genetics to addiction. The environment will tell you what you're gonna fall for. Is what your friends are using, peer pressure. I have patients that started, their parents gave them painkillers when they were 12 years old, and so it's the environment really that pulls the trigger.
Right. So with obesity, are the same parts of the brain triggered and affected as with substance abuse disorder?
Yep, it's your mesolimbic system, your reward system, all those areas I told you that that you're looking at your cheesecake or driving to your favorite restaurant, you start salivating and craving your cheesecake. And yep, it's the same thing. The prefrontal cortex is gonna tell you, don't eat it, you're gonna gain weight. Your amygdala is gonna stress out and tell you, no, don't eat it, because if you eat it, you're not gonna fit in your dress tomorrow. And or your hippocampus that's gonna tell you, yeah, remember last time we ate that, it was phenomenal, let's eat it again. So yeah, it's exactly the same circuit that works on all reward and pleasure.
Yeah. And the worst thing is to run into your cardiologist when you're picking up the cheesesteak. That's the worst. So at Lared, are behavioral addictions and compulsive disorders also diagnosed and treated?
Yes. Yeah, that there is no, yes, they are diagnosed and treated. That falls in the other area of the services that we offer, because there is not necessarily medications to treat, behavioral addictions like, sex, gambling, things like that. These are people that we use a lot of counseling for. Intensive counseling helps, strategies, and we can help them. A lot of these people struggle with depression for clear reasons. When they have these kind of addictions, they can struggle with depression, anxiety, PTSD, and so we can help them that way with medications. But we offer counseling for them.
Right. And so interesting, because as you were answer or making that statement, somebody had typed in, how are behavioral addictions like overspending and gambling treated?
As I said, counseling and different types of counseling, behavioral modification, like, basically teach them strategies to avoid falling into the same circumstances that are gonna trigger the relapse. So,
All righty. Is the statement, the older you are when you try to move past your addiction, the harder it is and the longer it takes, true?
again, it all comes down to how long you used and how much you used. So, there are many different factors. Unfortunately, as we get older, there are other factors that play a role into making it maybe a little bit more difficult to wean off the treatment for addiction. We could have started treatment for addiction, let's say 5 years ago, but now many of my older patients, I always try to push them to taper down, even if it's a slightly, just want to help them move forward instead of backwards. But a lot of patients tell me, doc, you know what? I have so much stress in my life. I cannot sleep. If you drop the dose, I'm having trouble with my arthritis, with my, things like that. I cannot sleep. So there are other factors that make it more difficult. But no, we are successful in most part. And most patients, once they have been free of illicit substances on treatment for a few years, they are also tired of this. I mean, this is they become in a certain way dependent to the treatment. What if you are gonna go take a trip to Europe? How are you gonna do if with your medications. You have to have them. It's not that you run out of, you know, you cannot run out of this. You're going to go into withdrawals in the middle of France, you know. So most people want to come off, but so it's not really related to age. It's related to other conditions that come with age that make it sometimes more difficult.
Right. And then somewhat related to that, have you ever had anyone as a patient who didn't stop using drugs no matter how hard they tried?
Yes, yeah, we have several patients that have not been able to stop using. And again, these are patients that have. Actually, as I was answering this, I have a few patients that come into my mind, and for the most part is environment, peer pressure, you know, exposure. That's one of the main things, you know. If you, and we all have gone through this, whether you are young or old, you know, if you have something in front of you that you really want and you really need, chances are under the right environment you're gonna fall for it. And so unfortunately, patients that struggle with addiction, they not just want, but they also need to have it. And if you know, they are living in the same household with somebody that is using their favorite substance, it's very hard. Those are the patients that usually struggle to recover, and they cannot move because they don't have money, it's their family, whatever. So it's the one of the main reasons why people don't recover fast enough is because of environment exposure.
Right.
Sorry, one more thing. So, and that's the main reason, because at the end of the day, if you think about it, most people really don't want to do this. I mean, these are smart people that say, why would I mean, I have to do it because if not, I feel terrible, but I do not, nobody really wants to be dependent on drugs. You know, it messes up all your finances, all your life. I mean, this is a job on its own. Whether snow, rains, storms, you know, doesn't matter. You have to find it. Patients tell me, I'm in the middle of the night waking up with withdrawals and, you know, calling my dealer every minute, you know, to find a way to get something. So it's very, it really changes your life in a very negative way. So.
Right. Um, Interesting question. How do you help people in denial of their addictions?
That's a very, very early stage. I mean, it's kind of hard to deny that you're addicted to something, especially to opiates, cocaine. Well, cocaine, usually people don't get addicted that easy. It's possible. But do we see that mostly with people that are in denial for alcohol and nicotine and marijuana? Those are the things that people tend to deny the most. People that are addicted to stronger substances, especially opiates or meth, crystal meth, they obviously there's no way you can deny that. It is what it is. I mean, you're withdrawing, shaking, sweating, aching, and if you don't have it, I mean, there is no way to deny it. But most people that deny it are people that abuse alcohol, nicotine, or marijuana. So how do we deal with that? You know, it's just education. You know, challenges. There is something called contingency management, like we give them sort of rewards for good behaviors. Like if you give me a clean urine, you know, you get, you know, a voucher for food, some things like that, you know, and or if you come and your urine has the drug again, then, you know, we cut down your prescription a little bit, you know, I have to monitor you closely. So instead of, you know, taking a prescription for a couple of weeks or a month, maybe let me watch you closer for a couple, you know, I'll give a prescription for a week. It becomes, you know, it's just a constant education and you know, just talking to the patients. Yeah.
so many good questions. So a question near to my heart. How can we entice new medical students to go into primary care and/or become addiction specialists?
As I said, from my personal experience, the best thing I can tell you is just the pleasure that you see when you help somebody that way, especially with addiction. I mean, you are walking with the path with these patients, and some of these paths are very difficult, and you are partners with them, and they confide in you. You develop a relationship with them, and 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 it's not just for addiction. As you're dealing with somebody with a bad disease, and they are about to, something bad happen, possibly die from this bad disease, and you work with them and you help them recover, and it's the gratefulness and of the patients and the reward that is, to me, the main motivation. If you want to be, it's important that whatever job you choose, you have to be happy in what you do, because you're going to spend most of your daytime in your job. So you better like what you do. And medicine is something that gives you pleasure. Unlike other jobs, that most jobs can have positives and negatives, of course, but medicine is something that every day is a new challenge, every day is a new experience, every day can be a great pleasure or a bad tragedy as well. But there is a lot of emotions in practicing medicine, and I think that is something that you don't find in many jobs. And of course, if you're looking for money, it's a good pay too, so.
Right. So, so that was addressing the question of how do we get people to go to become a physician? But another person is asking here, how can someone become a part of the team that's helping people rebuild their life in this field without extensive education and certification? Is there a place for people who merely care?
Yeah, the best way is what JC is doing. He's training to become a peer support specialist. So peer support specialists are people that meet with people that struggle with addiction. They share experiences, they share strategies. What did I do that worked? What did I do that didn't work? What is the risk? What happened to my family, my friend, my brother? They share all these experiences and help other people recover. So without any extensive education, people can help people that struggle with addiction by being peer support. You don't have to be certified for that, but you can get more comprehensive training, become a certified peer support specialist. It's a great tool that we use. People that have lived through that help people that are living through that.
All right, and Robin Morgan just put, DSAM has CADC class for free. I'm afraid I don't know. Robin, could you spell all that out, please, for us? Because I know what DSAM is, but I have no idea what CADC. We'll come back to that.
CADC are certified alcohol and drug
Oh, thank you. Okay, all right.
And so that's another way you can become a counselor. CADCs, or certified alcohol and drug counselors, they also provide counseling to us with some limitations, but counseling to patients that struggle with addiction. And yeah, I mean, I work with a lot of CADCs in a couple of the outpatient treatment programs, or where we prescribe methadone, we have to have counselors. Most of them are CADCs.
And DSAM is, I believe, a part of either public health or the State Department of Health and Social Services.
Right. It's the division that deals with substance abuse and mental health. Yeah.
And mental health, right? Okay. Here's a great question. How do doctors protect themselves from accidental needle pricks from well, from anything, but with addicts. And if something like that happens, what would be the first course of action?
So, of course, there are many well-established strategies to prevent accidental needle exposures or body fluid exposures. But it happens, it happens. So the first course of action is, well, we have a process that we follow. We obviously have to write a report to have documentation of what happened and why it happened so that we can prevent this from happening in the future. If the person who had the needle is our patient or allows us to inquire about his or her health, of course, we ask the questions, have you been diagnosed with HIV, hepatitis C, hepatitis syphilis, etc. And because that's important information. The medical personnel that got stuck by a needle, of course, will also have to be tested, and we get a baseline test for Hep C, hepatitis B, C, syphilis, and HIV, and we repeat that in 3 and 6 months. And so that's basically what we follow. There is also, if a patient is high risk and doesn't want to share information, or if we know that a patient has, for example, HIV, there is pills that the accidental people can take. It's called post-exposure prophylaxis without even waiting for a test result.
All righty. So two people, or perhaps one person twice, asked a very similar question, which is, what does a typical day look like for you?
Busy. Very busy. A typical day. In my typical day is probably not the typical day of most doctors. As I said, I love what I do, and I work in like a couple of places every day. So I start early in the morning and go to an outpatient treatment program where I see patients, treat them with methadone, because we can only use methadone in places like that. We cannot prescribe methadone in places like Lorette. And then I go to Lorette where I see patients. I do primary care. We treat, all primary care issues, obesity and substance abuse. I normally see in a day of work, I will probably see 25 to 30 patients, sometimes less. Yeah, probably between 15 and 25 patients, depends on the level of complexity. And I have some time set aside for administration work. One thing I can tell you, as busy as I am, I try not to bring work home. It's very important. Even if I have to stay a little bit longer at the office, I like to finish there so when I go home, I can enjoy my stay at home, my family, and that's very important for everything whatever career you choose.
Right. What are the long-term effects for a person who smokes marijuana?
There is some studies that show that long-term effects can basically affect cognitive functions, especially IQ. A lot of people say that marijuana is not addictive, but it can be. And the withdrawals from marijuana, if you use long-term marijuana, can be really severe and very long-lasting. I have a patient that he was using marijuana every hour, every day. And of course, he told me I'm not addicted. The typical thing, I don't have an addictive personality. I can stop whenever I want. And even though I told him he needed to gradually wind down, he came one day and told me, "Doctor, guess what? You got your way. I'm gonna have to stop smoking marijuana because I got a job, and I have to drive for the company, and they do not allow marijuana in the urine." So Sunday is my last day. Well, he came back Tuesday and he was in terrible withdrawals, and it lasted for a whole month. So, so that's, that's one potential harm that people don't understand. Marijuana can be addictive, and the withdrawals can last for 4 weeks for people that use high amounts and frequency, in high frequency marijuana. Cognitive dysfunction is long-term effect. Of course, depends on how you use marijuana. If you smoke it, of course, there is lung damage. There is even carcinogens in marijuana. But it all depends on how much you use. There is not many, most of the studies done on marijuana long-term effects relate to people that use moderate to high amounts.
All right.
A sporadic use here and there has not proven to cause any long-term damage.
All righty. Final question, which sort of allows a whole wrap up. What happens to the people who have relapses multiple times? Are there centers to help or medications that may help? So that's a great way to wrap it up.
Yeah, the treatment is the same. We see that all the time. Frequent relapses are frequent. It's not, drug addiction is not an easy thing to overcome. It's a major achievement for people. Relapses happen, and we expect that. So, and that's an important thing for people to understand. A lot of patients, I have this story of a patient that he came and he was doing fine for a while, and then he relapsed. He got a foot injury. He was prescribed painkillers, and then he relapsed. And then we treated again the same medication. He stopped for a while. Then he relapsed, and then he came, and then he was fine for a year, over a year. And then one day he comes to the office, and he didn't want to give me a urine sample. And I said, well, listen, it's not, this is not police here. I'm not going to judge you. I don't care what's in your urine. I'm here to help you. And if your urine shows something that shouldn't be here, then we can talk about it and we can see what we can do to help you, right? But he didn't want to. And finally he did, and he tested positive for oxycodone. And he said, sorry, for morphine. And he said, no, doctor, no, I swear I have not done anything. I ate bagels, with poppy seeds.
Poppy seeds.
Poppy seeds can falsely test. And that's what I was saying. You develop a relationship with your patient. So I knew, and I liked this guy a lot, and I knew that he was using, and we kept talking and said, okay. And, but so, and then I challenged him a little, and then he said, no, what happened is I got a bad tooth, and I went to, I was in North Carolina, and I had to go to an urgent care, and they gave me morphine. So what he didn't know is that we have access to all that information. So I checked the registry in North Carolina, and he had no prescription for morphine in North Carolina. So I challenged him again in a good way, listen, buddy, just this is the paper, there is no prescription in North Carolina for you. So finally he accepted, yeah, doctor, I'm sorry, I relapsed. And so it's gonna happen. The important thing is for patients to understand what I was telling this guy. It doesn't matter, it's gonna happen, My job is to help you make this less frequent and eventually completely stop. I'm not here to judge you. I'm not here to make you feel you're doing something bad. I understand this is a brain illness. This is a brain disease, and you're struggling with it. And there is nothing, doesn't make you a bad person. And that's the most important thing when we deal with people that relapse frequently, to help them understand that we are not here to judge. We're here to help and help them eventually stop the relapses. I don't know if that answered the question, but that was just an experience.
Well, doctor, thank you so much for talking about this with such compassion and kindness and so eloquently. We greatly appreciate you being here. Everyone, next week is the last week of MiniMed. We'll be hearing from Dr. David Tam, who is the CEO of BB Healthcare, who's going to be sharing a bit of his own personal story about having had a stroke and all of a sudden being a patient. So look forward to seeing you next week. This evening's presentation and recording should go up at delawareminimed.org sometime tomorrow. And we'll see you next week. Take care, everybody. Bye-bye.
Thank you. Bye-bye.